So my name is Rose Luckin and I'm a professor at UCL Knowledge Lab, and I'm going to introduce our speaker for today. And it's a real pleasure for me to come here and introduce Ami, because I first met him when I gave a lunch hour lecture here about 18 months ago. And since then, we've collaborated on a grant application and are finding various ways of working together. So it's really lovely to come back and introduce him to you. And when I said to Ami, what would you like me to say about you? He said, and I thought this was classically modest. He said, oh, well, I guess in your introduction, I'm happy for you to say that I'm definitely not an expert in AI. And I thought, yeah, but you are an expert in an amazing number of things. So Ami is definitely an expert in evidence-based healthcare and informatics, and most of all, patient-centered care. And when I looked at his CV, it reads like what I imagine any budding medic would want their CV to look like. So yes, he is a senior clinical lecturer in the clinical data science department in the Institute of Health Informatics here at UCL, and also an honorary consultant in cardiology at UCL, and is also leading the UCL Medical School's e-health curriculum, which is quite a lot to be doing. And then when I look through his CV, it has all of the names that you would love to see. You know, I studied medicine at Oxford Medical School, did a master's in public health at Harvard, a PhD at Oxford. You've worked for the World Health Organization. You are a clinical cardiologist, still practicing, and you are the education lead at the Health Informatics Unit for the Royal College of Physicians, a fellow of the Royal College of Physicians of London and of Edinburgh, and the European Cardiology Society, and the American Heart Association, and the Higher Education Academy, and the new Faculty of Clinical Informatics. What else can I say? I can't think of a better person to come and talk to us on this topic in our lunch hour. So as the sign says, bring your lunch and your curiosity. I haven't brought my lunch, but I have brought my curiosity. And I know you're going to enjoy this talk. So it's over to you, Ami.
Many thanks, Rose, for your kind words. So I am based at the Institute of Health Informatics here at UCL. My name's Amitava Banerjee, and I am also a cardiologist at University College Hospital and Barts. This is the conflicts of interest slide. I like to call it the limitations slide. As Confucius is credited as saying that real knowledge is knowing the extent of your ignorance. And I want you to be aware that I'm a clinician 30% of the time, 70% of the time I'm researching and teaching. I've previously worked with these pharma companies. There's a digital technology company called Medipad, which is funding research that I'm doing at the moment. And I'm also a trustee of the South Asian Health Foundation. I am not an expert in AI. I'm very interested in its applications to healthcare. I am interested in evaluation of new technology in healthcare, digital health, evidence-based medicine. So I guess I'm at that stage of life where my mum is sending me kind of inspirational and aspirational quotes. Used to be by email, I get them by WhatsApp sometimes. And she sent me this one when my daughter was a bit younger, saying that children are made readers on the laps of their parents. And when I tried to explain this to my daughter, she said, Daddy, it's not laps, it's laptops. So that's how big computers and AI is. And when you look in my Amazon feed at the books that I should be buying for her, this comes up. So, you know, everybody needs to know something about AI. So what is it? Well, for a simple doctor, I would say that AI is importantly about performing a given function. You're using that intelligence to perform a task. Machine learning is a subset where from the input data sets, the machine is learning how to get to the output, how to get to that task. And deep learning is a further subset still of machine learning where you have several layers of neural networks to reach that task. So Anu, my daughter, her task is to get Santa to bring her the gift that she wants, which is a Lego doll's house. So the machine learning was that she realized that just sending a letter to Santa isn't enough, and also putting a bit of push on Dad as well seemed to work last year. So she did the same this year, but the deep learning is that she asked Alexa, can you ask Daddy to buy me a doll's house? So she cut out the middleman, Santa. That's deep learning. And of course, our current Health Secretary, Matthew Hancock, within a week of joining as Health Secretary, he had signed a deal with Amazon Alexa to partner in delivering information. So you can ask Alexa for health advice. AI is one of the most written about topics. I don't need to tell this audience. And here's two heavyweights. So Mark Zuckerberg, founder of Facebook, is of course optimistic. He feels that there's going to be lots of improvements in our quality of lives. Elon Musk, serial entrepreneur, serial digital entrepreneur, feels that there's actually a risk to the existence of civilization. So, and this is characterized in almost everything you read about AI. It's either friend or foe, it's good or bad. There's not a middle ground. And right here in your university, in the hospital opposite, we're really investing heavily in skills and in terms of both clinical practice and in research at how we can apply AI to healthcare. What we're seeing a lot of is industry interest, industry presence. This is a series of co-sponsored articles that seem to be appearing in the Evening Standard with Babylon, a company which is all about virtual GP consultation, but it has AI as part of what it does in terms of symptom checking. And this was a report last year led by Lord Darcy, by the Institute of Public Policy Research, which said that we could save 12.5 billion a year in the NHS if we better used AI. And Theresa May latched onto that and said, in the next decade or so, we're going to save thousands of lives using AI in terms of cancer. Now, I'm a clinician, I said that. This is somebody I saw a couple of weeks ago in my clinic in Whitechapel at the Royal London Hospital. 53 years old, Bangladeshi gentleman. He's been more breathless over the last couple of months. Now it's so bad that he can't walk from here to the middle row of this hall. He had a heart attack 10 years ago. He's diabetic, he's got high blood pressure, he's on a pile of pills. He stopped smoking 5 years ago. So with this breathlessness, I organised what's called an echocardiogram, a scan to see if his heart is pumping well. And it showed this number, ejection fraction, EF, of 10%. That should be more like 55 or 60%. So this is not good. A mixture of his questions and my questions. What's the likely course of my disease, doc? What's my risk of dying in the next 5 years? I've got 2 kids. Are particular drugs more or less effective in this case? Should I refer him for a heart transplant? He's a youngish bloke. If so, when and what information should I base that on? So, heart failure is on a continuum. Your heart pumps normally. There's a phase where you might not have symptoms, but you do have heart failure. We just don't know yet. And you don't know yet. And there's a phase like this man where he's symptomatic, he's breathless. And what my job is, or the health system's job, is to try and stop him having the worst complication of all, dying, but also being admitted to hospital. And the point is, at the moment, we're not very good at predicting how things progress along this line. So one thing I can do, as a good evidence-based doctor, is look at the literature. So this is a study done in Sweden last year, 45,000 patients. They looked at how good a particular machine learning algorithm was at predicting 1-year survival. What they found was that the C statistic, which is a measure of how good a tool is at prediction, where 0.5 is like tossing a coin. So you want it to be as close to 1 as possible. So what we think as cardiologists is a good predictor, which is that ejection fraction, the measure of how well the heart pumps, that is as good as tossing a coin. But actually, machine learning improves that vastly to 0.8 in this particular study. But this is a Swedish study. Do these patients map to what I'm doing sitting in Whitechapel? So with one of my colleagues, Nick Chen, we've done a systematic review and looked through the literature to see what other studies have been done about heart failure and machine learning. And there are 22 of these studies. They never, other than one, have gone to another data set to see if these same results are found in another data set. They use different methods of machine learning, and mostly they're in patient groups of 1,000 or less, so they're small studies. A couple of them have involved industry, and it's not always declared, the conflict of interest. So for me and my patient, it's not clear how representative these data are to the patient that's sitting in front of me. So that's the prediction, how well am I going to do in the next 5 years part. This is the other question in my head about heart transplant. So when heart failure is bad, you get put on a waiting list for transplant, you have a transplant, and then you have hopefully a long survival after you've had a transplant. We only do about 200 of these a year in the UK. And so these are precious organs. So we need to do as well as we possibly can at picking the people who get a transplant and doing our best to predict how well they're going to do in the long run. The point is that the risk scores that we have at the moment are pretty poor at predicting both pre-transplant survival and post-transplant survival. They use a limited number of features and they're not individualized. So with my colleague Mihaela van der Schaar and team, we applied her paradigm of machine learning to a US database of heart transplant patients, over 50,000 of these patients over the period of 1985 to 2015, to see if we could improve the prediction of survival. So this algorithm that she's developed called Trees of Predictors uses more features. On average, the existing tools use no more than 8 to 10 risk factors or features. So by using more features, hopefully you'll have a more personalized approach to predicting risk, and you also want to be able to predict risk in a particular window. So we've been saying 1 year, but really patients want to know 5 years, 10 years. So instead of 8 or 10 risk factors, we ended up looking at 50 risk factors. And without going into detail, what this algorithm does is it splits that 50,000 gradually into smaller and smaller clusters so that you're predicting based on which cluster a patient is in. And what it showed is that from the existing risk scores and existing machine learning, in short, we went from, again, 0.6 C statistic, a bit better than tossing a coin, to more like 0.8 pre-transplant, but still around 0.6 to 0.7 post-transplant, whether you were looking at 3 months or 10 years. So our approach did improve things significantly for both pre- and post-transplant survival prediction. And the reason it did is because it takes into account the variations of the population. So this is using big data. It takes into account interactions between those different 50 risk factors, and it takes into account variation across different time horizons. But it's still far from perfect. I told you after a transplant, it's still a C statistic of 0.6 to 0.7. We want that to be 0.8 to 0.9. We need prospective studies. This is a retrospective study. And we need to do this in other data sets, possibly in a trial setting, to see if this actually works in the wild. And most importantly, is this usable by doctors like me, and is it usable by patients? Going back to my gentleman in clinic, what does good healthcare look like him? What does it mean to him? Well, there's lots of different variations. This could be a lecture in itself. But the WHO talks about health as being more than the absence of disease. It talks about social, physical, mental well-being. Definitely he'd like some of that. Universal healthcare is something that we've tried to do at the NHS since its inception. So that's about access and about having cost effectiveness. Evidence-based, yep, that sounds sensible. So we want something that is proven to be effective and validated with reproducible results. We want something that's high quality, so that it's got value to the individual, value to the health system. And then Muir, Gray, and others from Oxford have developed this paradigm of right care. So the right care for the right patient at the right time in the right place, which kind of captures all of the above. I like to think in the information era of learning health systems, which was a term coined originally by the National Institute of Medicine in 2006, where they talk about this wastage when you go from science, research insights are wasted, they don't get into guidelines and evidence. Wasted again, they don't get into care. And so they've produced this virtuous circle, the learning health system, where data is flowing freely between these three silos. And it's that electronic data, the digital data, that really makes this work. And that's where AI, at each of those steps, can make good healthcare. But in order for that to happen, what do you need? Well, you need data at the individual level, you need personal health records, you need it at the system level, electronic health records, population, public, and so on, but it has to be used and fed back all the way to the individual. So you need good science, good evidence, and good care. So do we have the science for healthcare? Well, this, I believe, is one of the best attempts to gather all the evidence for AI in healthcare and whether we are there in terms of science. Just note the last sentence here. Over time, marked improvements in accuracy, productivity, and workflow will likely be actualized, but whether that will be used to improve the patient-doctor relationship or facilitate its erosion remains to be seen. I'll be coming back to Eric Topol in a moment, but in this article, he very neatly shows all the exciting things that AI is being used for in healthcare and actually have been studied. So you've got in pathology, it's been used to diagnose or check diagnoses of breast cancers, of lung cancers. In ophthalmology, it's been used to look at retinopathy scans. In cardiology, my own field, it's been used to read scans, the echocardiography scans. But if you look, there are only 3 or 4 studies which have actually been done prospectively. The rest have been looking in the rear view mirror, retrospective studies. And probably the best data we have so far is in ophthalmology, but there are only 2 prospective studies, only 1 trial to date. So Eric Topol concludes that we're far from demonstrating very high and reproducible machine accuracy, let alone clinical utility for most medical scans and images in the real-world clinical environment. And he's coined this term, the AI chasm, where even if you have a really good predictive accuracy with an area under the curve of 0.99, you still do not have clinical utility unless you prove that. And that's where the holy grail of AI is and where we should be focusing. He talks in this paper about the accelerated FDA approval, so the body that approves the things that we do in healthcare to check that they're effective and safe. And there's now an accelerated different pathway for AI algorithms. Interestingly, only 2 of these have published data to match with them that you or I can access. So this is a worry that you've got an exceptional treatment of AI in a way that wasn't happening with other new technologies. And to answer the question whether my job is in danger from robots, he says, human health is too precious. Relegating it to machines, except for routine matters with minimal risk, seems especially far-fetched. So it's widely said that AI isn't the problem. It's the data that's feeding into the algorithm that's the problem, and I tend to largely agree with that. So, even if AI is ready, is the data in the NHS ready? And the answer is maybe not. IBM Watson is one of the most famous applications where they said they were going to transform the diagnosis and prognostication of cancer, and it hasn't done that. It hasn't lived up to the promise in the last decade by any measure. So I've divided up these different types of problems with the data that might contribute to this. I mentioned Babylon earlier, and they exemplify what I want to call the digital divide. So if not everybody has the ability to provide their data, then how are you going to be put into the algorithm for AI? This is a company that has symptom checkers for disease, but has initially been piloted in well patients, in people without the comorbidities, who are younger than most of the patients who I see in clinic or in hospital. So you're potentially making a divide, producing more inequalities. There's a data divide. If you look at genomics, one of the most optimistic areas of big data, in 2009, only 4% of the studies in genomics concerned patients who had non-European ancestry. In 2016, we're not yet up to 20%. So how can I benefit from an AI algorithm when my data was never in there? Who owns the data? This is arguably one of the most contentious issues. So the Royal Free Hospital got into a lot of trouble with the Information Commissioner because Google DeepMind accessed 1.6 million people's records. This is in the public record. Now, the issue is consent. The issue is who owns the data. Is it for research? What's for commercial purposes? And now there are further concerns because DeepMind and Google were at arm's length from each other, and they are no longer so. So is any research going on in that setting or otherwise going to be liable to linkage of health data and non-health data? It's hard to imagine not in a huge multinational company such as Google. Quality of the data. So that's in terms of, is there missing data, but also is there evidence of quality of an intervention? So this is mobile phones for diagnosing melanoma. This is one of the most exciting developments where people don't have to wait to go and see their dermatologist. They can take a picture of their tumor and the algorithm can tell you what's worrisome about that and whether they need to seek referral. So there's plenty of evidence in the press and in the literature that this is a good thing. But actually, when you look at the totality of evidence, the Cochrane review, the systematic review, the best way of looking at all the data for this application for melanoma shows that at the moment, smartphone applications using AI-based analysis have not yet demonstrated sufficient promise in terms of accuracy and are associated with a high likelihood of missing melanomas. So that's the important bit with AI, is are we missing important things, and are we telling people they're unwell when they're not? Are we overdiagnosing? Those are the two areas, like any doctor as well. There's standards that we need to maintain. So if you take heart failure, my patient has this disease, heart failure. It's defined differently across different study designs, across trials, across observational studies. It's defined differently in clinic versus the hospital. It's defined differently in research and hospitals. And it might be slightly different in America versus European data sets. So how are you going to cater for all of that in your AI algorithm? Because the data is messy. So the science is a question mark. What about evidence? Well, here we've got some interesting work going on, led by my colleague Harry Hemingway, also at the Institute of Health Informatics, where we've got a consensus document of what good looks like. what are the questions we should be looking for in any application of AI to healthcare for transparency, replicability, ethics, and effectiveness. And they've developed a set of 20 questions. This is in open archives in the public domain, and we should be using this to ask if data is usable and whether AI is ready and fit for purpose. And the NHS has also sat down, got together a load of key stakeholders from NICE, from the tech sector, and thought about what are the guidelines, what are the standards that we should seek for digital health technologies, and including artificial intelligence. What I'd say is that unfortunately this is just guiding principles. There's no requirement for any industry, any company to meet these guiding principles as yet. So I've talked about science, I've talked about evidence, care. So that's what I do in my clinic. We've got several problems here for AI. The first is training, the second is transparency, the third is clinical credibility, and the fourth is patient-centered. Well, we know that in this complex way that we train doctors from the 5 years at medical school through to the 10 plus years it takes to get specialized, that at the moment there is very poor provision of training in big data methods, in informatics, and definitely in AI for doctors at the moment. So at the moment we're working with the Royal College, with medical schools to see how we can develop this training, because the doctors of today and tomorrow are going to have to use this technology and evaluate it. And at the moment we're focusing on whether a hospital or your GP surgery is digitally mature, rather than whether I, as a worker in the NHS, am digitally ready. And that is obviously going to restrict what you can do with AI. So there's lots of work to be done in that space. And there's lots of big promises, but at the moment this is not reaching reality yet. So the World Economic Forum feels that this is the answer to China's shortage of doctors in particular. I think this is the biggest issue for AI going forward, is transparency. This company, Babylon, has had several big stories about it. One of them, which we've seen in healthcare many times, is a silencing of whistleblowers. So those involved in care who are worried about how data is applied aren't able to talk about it. And ultimately, if you're in this business, it's not like selling jeans or cars. If you are looking after people's health, there's certain principles that you have to follow. And so if you aren't able to call people out when the data is showing that you should, that's a problem. This is a story hot off the press from yesterday night on Twitter. So Juliet Bauer, digital lead NHS England, has led to a new turn in the Financial Times, the new revolving door from the health ministry to the health app industry. So this is a problem. There's freedom of movement for people to work wherever they want, but she's not had a period of gardening leave. She's not declared an interest when she's been promoting this app. Is that a problem? Yes, potentially. Any conflict of interest, any potential limitation on the use of knowledge and output needs to be declared. So the Darwin review of healthcare, I mentioned this. This has said that £12 billion can be saved across different professions, across various functions in healthcare. That's a massive amount of money, £12 billion. This is widely said to be an independent report. That's in the public domain. It's not on the front page of the report, but maybe we should know that. So Eric Topol, a cardiologist from the US, a real thought leader in the use of technology and digital technology in healthcare and in how AI is going to change things. He's been invited to do a review about how we train people in the healthcare workforce. Rose has been involved in that. And this is very exciting. There's a panel that's very august there from various domains to look at how we are going to train the workforce of the future. But again, these are the ones that I could find that aren't declared in the document. There's people working for companies that are very interested in this space who are on the board, and also there's nobody in that lineup who's clinically active at the moment. Not one. So neither a nurse, nor a doctor, nor a physiotherapist, nor anybody. So would you do that if you were talking about AI in the air industry, in the plane industry, sorry, where we often compare healthcare with planes? Would you have a panel of doctors, of people from business, but exclude pilots from the panel? I don't think so. I don't think so. So this is a concern. And also, we don't have any patients there. The only people we do have is these clinical fellows who are the trainees, the younger doctors, who I believe should be more involved, and they are only invited to contribute to the board's thinking as helpful. And then Matthew Hancock, our health secretary, has set up this technology expert panel, which is, again, very much focused on how we can roll out digital technology, particularly AI. So it's led by a champion of evidence-based healthcare, a researcher, a clinician, Ben Goldacre. But if you look down the list, there's not one person there who's clinically active in the NHS. There's lots of people who are in finance and investment and venture capitalist and from industry, but where are the patients? Where are the clinicians? Where are the people who are doing research in AI? Are you going to be surprised if this health tech board says, let's roll out a particular AI technology? Of course not. So Ben Goldacre's next book might be Bad Digital. And the bit that I think really might suffer is patient-centeredness. We use this word very fluidly in research and in clinical practice. We are for patients, and we're seeing it a lot in the AI space, in digital technology, that it's more patient-centered. But actually, you just saw 3 boards at government level which involve 0 patient input. The only way patients can get involved in that is by putting in comments afterwards, and we know they won't do that. So we have to get out there and produce resources like led by the Wellcome Trust. There's this initiative, Understanding Patient Data, which I've advised on, but actually it doesn't tackle AI, really. And we need much more of that to give good quality information about what AI is, how to know, how to evaluate and know the wheat from the chaff. What else might we do with patient-centeredness? Well, who's heard of this website, They Sold It Anyway? Okay. So They Sold It Anyway. Do look at this later on. This is the NHS Digital's data release registers. It lists every single company, hospital, clinical commissioning group, university that might have broken the rules. It said that if people opted out, it wouldn't use their data, and actually they have. Unfortunately, you'll see my institution, UCL, is listed there. It's also listed in terms of the other side of organisations that have not breached the rules. But this is constantly updated. So it's not so much a problem that people have breached the rules. Of course, that's a problem. But at least it's in the open. You can see what the breaches are, what the organisations are doing about it. This is what patient-centred or public-centred or patient-facing looks like. So back to my patient. I've got to say, on the basis of what I've told you, I don't have evidence yet that I can drive risk prediction and tell him anything on the basis of AI for his heart failure. I've got to say that at the moment we are overhyped rather than underused. And that's because we don't have the data to get the most out of the AI. We don't have the ways of evaluating that we'd like. And we don't have the training for people like me and my patients to actually understand what it all means. And then, perhaps most importantly, a lack of transparency in the culture. So we need to move all these three spaces along. The science needs to go from unrepresentative data to representative data. We need the evidence space to go, rather than breaking up each patient-clinician encounter into little widgets of care, we need to think holistically about a patient's pathway and take advantage of the data that might be available and answer questions that are relevant to the whole patient pathway. And then these words, data-driven, technology-centered, I lose more and more hair every time I read these terms. Because actually where we want to be, I've never had a patient ever say to me, I need more technology in my healthcare. I've been doing this for 20 years now. I've never had somebody say, I want more technology. I have had people say, I want my data. I want to know what's happening. I want better communication. I want it to be about me. That happens quite a lot. So that tells me that we do need to be more patient-centered and more data-guided. This is one of very few pieces of work, to my shame, that I've done, but co-authored with patients, where we talked about what actually does using patient data look like. Data saves lives. Well, how does it really save lives, and how could it for patients? Last two slides. So my Christmas reading included this. This is a really excellent book, and this quote says, in the early 21st century, the train of progress is again pulling out of the station, and this will probably be the last train ever to leave the station, called Homo sapiens. Those who missed the train will never get a second chance. In order to get a seat on it, you need to understand 21st century technology, and in particular, the powers of biotechnology and computer algorithms. This other book that I also read over Christmas is why we can't afford to get this wrong. We can't have another Theranos, another technology company which was based on bad data or bad evaluation. We have to do better. Thank you very much.
Thank you, Ami. So many parallels with my world of education and AI. Really interesting, especially all those points about ethics and transparency. Now, time for questions. And if you'd like to ask a question, please wait till you get the microphone before you ask your question. So, any questions? Must be some. Yes, there's one up the back there.
Hi, thank you very much for your talk. Thursday saw a sellout lecture of Ali Parsa, the founder of Babylon, speaking to UCL mostly medical students. Most medical students and scientists will be familiar with the book How to Read a Paper, which basically tells you how to critically appraise evidence and research. So how would you, what would you say to those medical students about how to critically appraise or how to challenge or assess someone like Ali Parsa or Babylon when they come and present, so they can make the best decision about whether to use that technology, whether to even leave medicine and join the company?
Thank you, Maxine. I think, firstly, you need to have published evidence. If I'm not publishing my evidence or putting it somewhere where people can see, until proven otherwise, I've got something to hide. And there's plenty of evidence that the symptom checkers and so on from Babylon are substandard. They're not safe. And so, number one, look for published evidence that you can see. Number two is, if the claim is too good to be true, it probably is. And thirdly, what we're seeing worryingly in the digital tech space is there are some people or companies that seem too big to fail or too big to question. How is this company allowed to carry on the way it is without these simple questions when, you know, there's certain hoops that I have to jump through as a researcher to do a very small piece of research for, you know, one millionth of the amount of money that they're turning over. So I think all of those, as well as the training that they've had in evidence-based medicine, would easily help them.
Thank you, Ami, for the wonderful lecture on AI, whether it's a hope or hype. I'm Ganesh. I'm a physician myself, and I have developed interest in artificial intelligence in healthcare. A couple of weeks ago, I've been to one of the Google artificial intelligence conferences, and the tech world is now calling data as a new oil and artificial intelligence as a new electricity. So that's the kind of hype which is being promoted by the tech industry. Then it comes to the next question is, the algorithm, the comment rather, the algorithm is as good as the data. So the good the data, the collection is, and the standard how it's collected will determine how good we could train the algorithm. The problem with NHS is the data is fragmented, and the data which is collected is not standardized. So which then begs the question, do we then have to educate the doctors, like you said, the clinicians and the healthcare professionals, how they collect and kind of quantify, collect the data for future use in artificial intelligence. So my question is, when it comes to the medical schools, the upcoming graduates in medical school, should they not have any course in health informatics, like a module in health informatics, which will teach them how to collect the data?
So the easy answer to all the statements that you've made is I agree and yes. And so, various people are working on it.
So the reason I wanted to ask you is because you are in health informatics and you are in the college as well. So how soon are we looking at for it to be implemented?
I think we're still at least a year away. There's a question up
there. Thank you very much for a most interesting talk. You mentioned that there might be a difficulty in having firewalls between various companies such as Google and DeepMind. I read last week about one company that claims to be able to perform certain diagnoses, particularly in cardiology, diabetes, as an example, on voice alone. Now, our voice is something that we give away all the time. And how could this ever be regulated, do you think?
So I would give you the same answer as I gave to the last question, that until I see a published study with proper analysis and independently done, rather than a claim from the CEO of that company, I can't judge whether it's good or bad, and the likelihood is that there is no data. One of the reasons, if you're skeptical, that people are looking for all of those kinds of non-health related data sources is because they can be gathered by the Alexa sitting in your front room, by your mobile phone and so on, which are already being captured in a way that is not regulated like your electronic health record. So the really clever thing would be when they can link that to your, or the clever or worrying thing is when they can link that to your health data. Yes. Yeah. Another question there at the back.
This is the last question.
Thank you very much for the very good lecture. I don't know if you're the right person to ask, but this is basically regarding global health. So in global health, we have this huge hype in mHealth and mobile application. The two recent one I've heard of was Peak for the eye, for scanning the eye, and Safe Delivery app. My question is, how do we get people to be accountable for what they promote in these countries? Because we're talking about accountability here. where we have big organizations to safeguard patients. But in developing countries, we don't have that. So how can we get these industries or these companies promoting their app accountable for whatever they're doing with patients who do not have anyone to protect them?
Yeah, thank you. That's a great question. I declare an interest. I'm doing a project using mobile phones to track whether people are taking their medicines or not in South India. And the first check on what you've just described is the culture of academia, not just industry, also of university academics that stops you doing that kind of work. Whatever you're doing here, the same rules apply in another country. Secondly, it has to get through ethics committees, which are having to follow international standards. And thirdly, I would say that you need to look at how these things are funded. So, for example, Babylon has done a lot of work in Rwanda. And if I was involved in that, I would want to know, what are they funding exactly? What is the evaluation of what they're doing there? Because the algorithms that they've developed here, which are not, I've already described how they're not necessarily fit to be used, I would argue they can't be fit to be used in Rwanda. So how are they developing their data and their applications there? So it's that mixture of things. Sorry if that's a mixed up answer.
So that was the last question. We'd like to thank you all for your questions and for coming to this really well turned out lunch hour lecture. And obviously we'd like to thank Dr. Ami for his fantastic lecture as well.
Thank you.